Hi guys, welcome back. We shall be talking about aspergillosis now. And well, this organism would be having multiple subtypes like Aspergillus niger or Aspergillus fumigatus. So we are going to obviously talk about them. But at the outset, you can notice that I've shown you a CT chest here. And one of the very characteristic feature that is seen in invasive aspergillosis, especially with a lesion that is seen around where the actual location of the fungus is present in the lungs, and that is called as halo sign. So though you read about halo sign with respect to CSF also, you read about CSF otorrhea with respect to middle cranial fossa fracture, or you read about CSF rhinorrhea with respect to anterior cranial fossa fracture. So we do read about halo sign in ENT also. But today I'm teaching you about a sign in internal medicine that is seen in a CT chest, the classical halo, which is like as if there's a lot of illumination around the original lesion. And as the lesion will progress, it might result in a destruction around the lung. So you can also notice another very characteristic lesion which is shown here, which is called as air crescent sign. You can see the air which is present around the initial fungal wall, which is growing inside this cavity that has developed in the lung of the patient. So air crescent sign and halo sign are two very classic images which I want you to be aware of. And well, let's just quickly talk about the subtypes of aspergillus which is to be asked. Do not mix this up with thermophilic actinomycetes, which is seen in Bagasusis. So I do find people mixing up thermophilic actinomycetes versus aspergillosis. So we are talking about aspergillosis fumigatus or niger at the moment, whereas actinomycetes thermophilic is related to Bagasusis. That would be related to sugarcane dust. Aspergillus fumigatus is an important cause of a lesion by the name of allergic bronchopulmonary aspergilloma, which is a hot topic for examiners. So we'll study about that. Then, especially in diabetic patients, you could be having an angio-invasive infection with Aspergillus niger. This can result in a cavity formation in especially diabetics. And the bad news is that this organism being angio-invasive can contribute to development of massive hemoptysis. So lots of times, especially chronic aspergilloma, pulmonary aspergilloma might actually go undiagnosed, or you might think it is tuberculosis, you might think it is sarcoidosis. So lots of time misdiagnosis of chronic pulmonary aspergillosis is done, and by the time we realize our folly, we might actually lose the patient due to massive hemoptysis. So obviously, this infection with a fungus would be seen in neutropenic patients, patients with low immunity, but the mortality rates with these fungus is relatively very high as compared to normally what we expect. Then a third variety that is asked is Aspergillus flavus. Now for Aspergillus flavus, I would like to remind you the fact that it is not only responsible for sinusitis, but it is also responsible for producing a toxin by the name of aflatoxin. And you would have read that this aflatoxin then promotes development of liver cancer or hepatocellular carcinoma. So yeah, this allied aspect is also to be remembered, apart from the infections which could be associated with this fungus. Now, who are the people who would be suffering from this particular infection? So we need to study regarding the risk factors for development of aspergillosis in an individual. These people would obviously be having low immunity. So patients of febrile neutropenia due to any etiology could be having angio-invasive infection with niger. Then could be AIDS positive patients, leukemia patients, patients on chemotherapy, which could result in decrease in the immunity levels of an individual. Patients who are on steroids for long duration. Patients who are on infusions of infliximab, which are given in patients of ulcerative colitis, Crohn's, or even ankylosing spondylitis, they could end up with development of aspergillus infection. And yeah, you need a concomitant damage in the lung like tuberculosis or COPD, and even cystic fibrosis patients tend to have a higher incidence of allergic bronchopulmonary aspergilloma. In fact, I would like to highlight the fact that both asthma and cystic fibrosis patients, they have a higher incidence of developing ABPA. In fact, that's an MCQ statement which is to be remembered. Cystic fibrosis and asthma are conditions which are associated with allergic bronchopulmonary aspergilloma, and the leading organism for allergic bronchopulmonary aspergilloma is Aspergillus fumigatus. Now, why are we so paranoid is because this organism or these organisms groups are angio-invasive, and as I was saying, the mortality rates are high. So for invasive fungal infection with the aspergillus, the mortality rate approaches 100%. Now that looks very shocking, because in dengue virus we study mortality rate of 1%, and in untreated dengue we study a mortality rate of 20%, and here I'm teaching you invasive aspergillosis mortality goes up to 100%. If it is chronic pulmonary aspergilloma, the mortality rate is close to 50%, because again I said life-threatening hemoptysis could be occurring in a patient, and lots of times there's a delay in diagnosis. But if it is allergic bronchopulmonary aspergilloma, then obviously the mortality rate is less than 1%. So do remember my statement, these organisms are angioinvasive. That is why we are talking about a close to 100% and a 50% mortality. Now, where would a person acquire this infection from? So the infection will be acquired obviously from dust, because this fungus basically grows in decaying matter, decaying compost. So inhalation of dust which is containing conidia of this fungus could contribute to severe lung infection in an immunocompromised patient, and therefore when you do a lung biopsy in the patient, you would be able to identify the hyphae. I want you to remember MCQ wise that when it comes to aspergillus, the hyphae are relatively thin, and you can also see the fact that they are branching at approximately 45 degrees. So I'll just mention, or I'll just use an alternative color to show the branching pattern here. The branching is occurring at, let me say, 45 degrees. So do remember this MCQ statement, because this has been given as an image-based question. The hyphae were branching at 45 degrees, which is aspergillosis. But if you look at the right side image that I have shown here before you, then this would be gomorimethamine stain. This gomorimethamine stain is showing the hyphae to be relatively thicker. So I'm using the word ribbon-like hyphae. And these ribbon-like hyphae have been are present to have branching at, let me say, close to 90 degrees. The branching wherever is occurring is close to 90 degree. So this presentation on the right hand side, where the branching is occurring at a right angle, is a feature that is encountered with mucormycosis, rhinocerebral mucormycosis. This infection, rhinocerebral mucormycosis, is common in diabetic patients. It is invasive. It can go into the brain, and it can contribute to aggressive behavior, because frontal lobe of the brain can be involved. So do remember the statement of mine. If the hyphae are at 45 degrees and it's a routine stain where you can see pink and blue, then it's gonna be aspergillus. If it's a gomorimethamine stain specifically with thick ribbon-like hyphae with branching at 90 degrees, then it is mucormycosis, which is to be remembered. So, well, let's now look at the important aspects from the clinical domain for these patients. So, we will first talk about what's going to happen to a patient who's having an acute pulmonary aspergilloma versus a chronic pulmonary aspergilloma. In acute pulmonary aspergilloma, lots of time death may occur before the diagnosis may actually be made in the patient. So we need to be a little fast in our diagnostic skills. The respiratory distress is out of proportion to the infection in the lungs of the patient, and there can obviously be high incidence of bleeding tendency, that is hemoptysis, which is a big risk in these patients, can definitely cause loss of the patient. So how would you diagnose acute pulmonary aspergilloma? You will use sputum, and you will go in for antigen detection using PCR technique. That's obviously a real-time PCR that would be useful for evaluation of these patients. RT-PCR will be superior to a fungal culture, because with respect to fungal culture, I would just like to say that the accuracy may not be so high, and secondly, the report might take a long time to come. So the best way to pick up a lung infection would be to evaluate the sputum for a real-time PCR. When it comes to histopathological examination, though I've shown you an image, I'll just, for completion's sake, mention this fact. The hyphae would be branching at 45 degrees. Though lung biopsy is something that is usually would be done post-mortem if the diagnosis has not been made, and in case you do a HRCT in the patient, it will be showing a very classical halo sign and an air crescent sign. For management of this patient, we need to be using not amphotericin B, because that's the commonest mistake that most people make. They tend to answer amphotericin B for every fungal infection, but for this one, the answer would be given as voriconazole. And if he asks you what is going to be given for prophylaxis for this, then the answer would be given as fosconazole. So do remember the names here: voriconazole for acute pulmonary aspergilloma, and for prevention it is fosconazole, which is to be used in the patient. Now let us compare this information with that of chronic pulmonary aspergilloma. Chronic pulmonary aspergilloma is usually misdiagnosed as tuberculosis. In chronic pulmonary aspergilloma, you might be actually able to see a fungal ball in a cavity. In fact, sometimes this fungal ball might be coughed out by the patient. In fact, Harrison says that in 10% cases, the fungal ball in the cavity might be coughed out by the patient also. Misdiagnosis of chronic pulmonary aspergilloma, because it is developing inside a cavity, could be misdiagnosis as TB, or it could be other lung conditions like sarcoidosis, or it could be atypical mycobacteria. So lots of time we are on a wild goose chase before we actually are able to diagnose this disease. We now come to the most critical part of the discussion, and I would like you to remember information for the next part very carefully, because I will explain to you regarding a lesion that is called as ABPA, that is allergic bronchopulmonary aspergilloma. So ABPA, you need to remember, is associated with aspergillus fumigatus, and you would be today having an asthmatic in your OPD or a cystic fibrosis patient, a teenager with cystic fibrosis, that is also called as mucoviscidosis. This is an autosomal recessive condition with a defect on chromosome number 4. The mutation is CFTR, and cystic fibrosis in India usually cause death due to recurrent pneumonia, but abroad, due to good medical care, they're able to make this patient survive. So you have a teenager who's coming to you with cystic fibrosis. Is a known case, and the complaints are those of coughing bouts. So asthmatic or cystic fibrosis patient is having this, it's like he says that I just can't stop coughing, and also says that there is thick tenacious sputum in the expectorate of the patient. There could also be history of shortness of breath in the patient, or dyspnea on exertion. So I'm just writing in short, SOB means shortness of breath, or DOE means dyspnea on exertion in a patient. So let's look at how am I gonna evaluate this person with a thick tenacious sputum plugs. In the workup of the patient, the first thing I will do is check for eosinophil count. The absolute eosinophil count of these patients would be increased. Normally is 40 to 400. Here the eosinophil count is very significantly elevated, and then I will be doing a HRCT chest. When I do a HRCT chest in the patient, it can reveal presence of central bronchiectasis. So do remember the fact that in invasive aspergilloma, you read about halo sign, you read about presentation of air crescent sign, but here we are studying about HRCT showing us central bronchiectasis, which is an important MCQ. And you can also see the hyper attenuated mucus. You can see the mucus, the thick attenuated, or rather I would say the thick tenacious plugs of sputum that are stuck inside the airways. So hyper attenuation of the mucus will definitely be seen, or incipitated secretions as a word might be written in the question. You will now be doing a test by the name of immunoglobulin E antibody levels. Immunoglobulin E, that is allergic response, IgE levels for aspergillus. This is one of the important diagnostic criteria, that in this patient not only the eosinophil count in the patient is increased, but even the immunoglobulin E antibody specific for aspergillus would be increased in the patient. Then you will check the total immunoglobulin E levels, which are astronomically high at more than 1000 international units per ml. So two things have to be remembered. One is total immunoglobulin E, second is immunoglobulin E against aspergillus for the patient. Another diagnostic criteria is a positive skin prick test. So they have developed a positive skin prick test, or a skin prick test, and it's another thing to be remembered for these patients is a positive skin prick test. So these are the diagnostic criteria which will help you in identifying ABPA, and then you can initiate treatment for the patient. What is the treatment that is given in this case would be given as itraconazole. I hope you are spotting the difference. When I was talking about invasive or chronic pulmonary aspergilloma, I was talking about voriconazole, but for allergic manifestations, it is itraconazole which is to be used in the patient. Now, these criteria have gone a sea change over the couple of years. 20 years earlier, the diagnostic criteria were more expansive, but now they've simplified the aspect for us. So if you are having these features present in a question, that means the patient is having ABPA. I would also like you to remember that if these criteria are not met, especially like the skin test is not positive, or IgE is not more than 1000, or IgE antibody for aspergillus is turning out to be plus minus, Then if the criteria in this case are not met, then the diagnosis of the patient is called as SAFS, very peculiar term, severe asthma, because the history would be any much there, no coughing bouts in a patient, thick tenacious sputum plugs in a patient. So it is severe asthma with fungal sensitization, that is SAFS. I want you to remember both of these terms. One, I have taught you regarding ABPA, allergic bronchopulmonary aspergilloma. Second, I've taught you SAFS, that is severe asthma with fungal sensitization. And these two diseases are referred in Harrison as fungal asthma. So that's again an MCQ statement, guys, that I want you to remember, that what is fungal asthma. It is either the two terminologies, that is ABPA and SAFS. So this is not actually a proper colonization of the lungs, but it is a hypersensitivity reaction to the fungus which is occurring in this patient. And for these patients, we will be using itraconazole. We can look at the CT findings once again. In one of the CT findings, you can definitely notice this very characteristic fungal wall which is present here. So one, I have shown you aspergilloma, which is a feature of chronic pulmonary aspergillosis. This is a fungal ball growing inside a cavity. Then I've already sensitized you to the presence of halo sign. You can see the area that looks illuminated around the initial growth. Then I have shown you already regarding air crescent sign, which is due to growth of the organism in the cavity again. So you can see a rim of air around the area where the fungus is growing. And in the inferior image, you can see these dilated airways. You can see these incipitated airways where the thick tenacious sputum is stuck up. So this is what I was talking about in allergic bronchopulmonary aspergilloma, where you would be able to see these dilated airways. And this CT scan basically represents central bronchiectasis. You can see the dilated large airways in the lung parenchyma of the patient. So these are some images which I definitely want you to remember, because most of the time if they're going to ask you about aspergillosis, they are not only going to ask you about, so when they're going to ask you about this topic, it's not only going to be the clinical domain, but they will obviously link it up with the radiological image. So it's a good idea to remember it. Earlier, the diagnostic criteria for this condition were called as Rosenberg-Patterson criteria. So there was a mnemonic for it, for that was called as RTPICS. And some of these features are not used. Like nowadays, we don't use criteria like a fleeting pulmonary opacity, because if I use this with fleeting pulmonary opacity, it would be counted in a lot of conditions. No, fleeting pulmonary opacities can be seen with drugs also. It can be seen with the parasites also. I mean, fleeting pulmonary opacities can be seen with fat embolism. They can be seen with tropical pulmonary eosinophilia. So nowadays, we don't use some of these criteria. So some of them are definitely there, like antibodies, immunoglobulin E in the serum, central bronchiectasis, fungus specific antibodies like immunoglobulin G and immunoglobulin E, but the initial criteria were called as Rosenberg-Patterson criteria. So that's the name that I want you to remember, not the criteria per se. What are the criteria I want you to remember? I'll go back to my original slide. I want you to remember these features. I mean, an asthmatic or a cystic fibrosis patient presents to you with what looks like an asthma exacerbation. In asthma exacerbation, you have difficulty in breathing. Here also you're having difficulty in breathing, and he's coughing on a regular basis. But you notice the fact that he's having the following features, which is especially central bronchiectasis, a markedly increased eosinophil count, and yes, I mean, these three must be written in the question, or these must be demonstrated in the patient for you to say ABPA. Immunoglobulin E for aspergillus, total immunoglobulin need to be more than 1000, and a positive skin prick test for aspergillus, which has been specially developed for aspergillus fumigatus, is the main reason why we are discussing this topic. I mean, these features must always be demonstrated in the patient. And when it comes to the treatment of aspergillosis, because I said multiple things, I'll just put them at a single spot. If the question simply says patient is having acute exacerbation of ABPA, that is allergic bronchopulmonary aspergilloma, and what is the drug for management of it, then the answer would be given as steroids. Yes, looks surprising, but true. They give steroids in acute exacerbation because this is a hypersensitivity reaction to the fungus. But if the question simply says what is the treatment for ABPA, that is allergic bronchopulmonary aspergilloma, then I'm quoting Harrison that he has ventured in the table itraconazole for management for acute exacerbation steroids. However, if we will use the word invasive pulmonary aspergilloma, which can be of two varieties, which can be acute or chronic, acute, we may lose the patient even before the diagnosis is made. Chronic can be misdiagnosed as tuberculosis or sarcoidosis. We shall be using voriconazole for the patient. For prophylaxis, we will be using osconazole in the patient. So these are the drugs which are to be remembered for this particular infection. And most of the questions that would be asked on this topic would be in relation to asthmatic cystic fibrosis patient, or they might give you a radiological images like these, and they might ask you a diagnosis related to a neutropenic patient with the following profiles. Also remember this slide once again. I'll show you once again. If they give you a slide in which you are noticing the fungal hyphae at 90-degree angle gomorimethamine, a green slide with black wavy like ribbons, that is mucormycosis. Rhinocerebral, specifically diabetic patients, could be having a black fungal mass, or for that matter of fact, they could be these at branching angles at 45 degrees, which would be for aspergillus. So we now come to the most important part of this discussion, that is to talk about a test by the name of beta-1,3-glucan test. You see, doing a real-time PCR is expensive, and fungal cultures will obviously take some time to turn positive. So we were always looking for some easy pan-fungal tests, especially which can pick up invasive fungal infections. So now we have this test available by the name of beta-glucan, which can pick up invasive tests, like it can pick up Candida. Invasive Candida infection could be occurring in patients of febrile neutropenia. This test can also be positive in Cryptococcus infection, cryptococcosis. So yeah, it is positive in cryptococcosis. I have a reference for that from Harrison. If you want it, you can message me across. And then could be aspergillus, which is obviously the infection that we have talked about. Then is pneumocystis jirovecii, which is a common infection in AIDS positive patients. But beta-glucan test is not accurate enough to identify mucormycosis. So this pan-fungal test is due to a fungal antigen which is present on the cell wall of most of the hyphae of all these infections, but is not seen with mucormycosis. I'm just putting across here, and this question has been repeated multiple times. So do remember about this relatively less common but a disease which causes a high level of mortality. I mean, the very surprising thing that I said in this, especially this part of the lecture, was 100% mortality rate for invasive pulmonary aspergilloma, going up to 50% for chronic pulmonary aspergilloma. That's because of the angio-invasiveness of this relatively harmless looking fungus. I mean, doesn't cause problem in you and me, but in people with low immunity, it can cause mayhem. So keep working, guys, and I will discuss another topic with you subsequently. I would say, I would like to quote here Sylvester Stallone in Rocky movie. If you watched movie Rocky, he played a role of a boxer who was to fight against a guy who's much more stronger than him, and he said it ain't over till it is over. What do you mean by it ain't over till it is over is till you call it quits. I mean, it's still the fight is on. So you need to push yourselves to a limit that the exhaustion word goes out of the dictionary. You have to keep on stressing yourselves on a daily basis. I'm not saying undue stress, but yeah, you need to put that extra half an hour, extra 1 hour into study, where when you are, maximum tired at the dead of the night, and you are like, to hell with everything, and you feel like throwing the books on one side and you say, I'm gonna sleep. That is when you start, studying another 15 minutes, another 30 minutes. Try pushing yourselves, push your limits, guys, and your brain will, our brain is very elastic or plastic, as they say. So our brain will be able to adapt to that information inflow that you will do. And all of us, we are doctors. We are bred on the concept of reading hard, and reading hard is not that I am asking you to cram, but I want you to read, listen every day, because you keep on adding those bits into your brain, and then your knowledge keeps on exponentially increasing. So that's all for this particular discussion, guys. Thank you so much for listening, and I'll see you on another discussion. Thank you.